Good day, everyone. Thank you very much for joining us today in this session for Medscape. We're going to be discussing medium and distal vessel occlusions hot off the press after the International Stroke Conference presentations. My name is Thanh Nguyen. I'm a stroke and interventional neurologist, and I'd like to send the microphone over to our colleagues, Professor Urs Fischer, who is the PI of the DISTAL trial.
My name is Urs Fischer. I'm a clinician scientist and I'm the director and chairman of the Department of Neurology at the University Hospital in Bern, Switzerland, and I'm president-elect of the European Stroke Organization.
Professor Mayank Goyal, if you could introduce yourself.
My name is Mayank Goyal. I'm in Calgary. I'm a neurointerventionist. And along with my colleague Michael Hill, we led the ESCAPE MeVO trial.
Wonderful. We'll begin with Dr. Goyal about a brief summary of what you learned from the ESCAPE MeVO trial and why did you conduct this trial?
Starting 2015, there were all these dramatic changes in stroke care related to large vessel occlusion. And as time went by, it was becoming increasingly difficult to find a subgroup in which there was no benefit of endovascular thrombectomy. In the meantime, what we found was we were getting better at tackling medium vessel occlusions. Technology was getting better. Technique was getting better. And starting around 5-6 years ago, we started working on this idea. We wrote a couple of editorials. We defined what MeVO is. We were very fortunate to have a large data set here in Calgary. And we wrote papers on natural history. We wrote papers on primary versus secondary medium vessel occlusion. And overall, what we realized based on the data set that was available to us, less than 50% of patients reach MRS-01 with so-called standard of care. So that's when we started exploring the idea of that can we improve outcomes further, given that they were not the greatest to begin with. And we started to design what ended up becoming the ESCAPE MeVO trial. The trial was a standard probe design, open label randomized trial. We conducted across Europe and North America, total of 530 patients, randomized 1:1. The treatment arm was endovascular thrombectomy plus standard of care versus standard of care. If the patient was eligible for thrombolysis, they got thrombolysis based on local guidelines. Patient had to be within 12 hours of onset of stroke, had to have documented medium vessel occlusion, had to have deficit that was commensurate with the medium vessel occlusion, try and avoid patients with secondary MEVOs if possible. For example, if the basal ganglia was down, then you do not include the patient, and was thought to be endovascularly eligible. We wanted to somewhat standardize the device use. So the first attempt at endovascular thrombectomy had to be with a solitaire device. Subsequent attempts could be whatever the physician felt comfortable with. There were very few crossovers, very few adverse events, but a summary sentence result was there was no difference in outcomes between the treatment arm and control arm in the modified Rankin score or any other outcome that we looked for example, 24-hour NIH quality of life. So the trial was completely neutral. We were unable to demonstrate any benefit for endovascular thrombectomy. There was a slight increase in adverse events in the treatment arm. For example, there was increased pneumonia, which we thought could possibly be related to a use of general anesthesia. One good thing was there were not too many procedure-related complications. The safety analysis overall wasn't concerning. We didn't have too many intracranial hemorrhages as a consequence of the device or the thrombectomy procedure. We did not have any significant groin complications.
Outstanding. Many congratulations, Professor Goyal, Professor Hill, Dr. Ospel, for this amazing accomplishment. I'd now like to turn the microphone over to Professor Urs Fischer. If you could help us summarize the DISTAL trial.
The rationale is similarly the same as in the ESCAPE MeVO trial. So we did a survey in Switzerland and we were looking how many people with a medium or distal vessel occlusion do have a good functional outcome. And we do have the so-called Swiss Stroke Registry, which is a nationwide registry. And looking at this registry, we saw that modified Rankin scale of 0 to 2 in people with medium and distal vessel occlusion is roughly 49%. So this gave us the rationale to do a trial comparing endovascular therapy plus best medical treatment versus best medical treatment alone. And the aim was almost the same as in ESCAPE MeVO. So overall, we aimed to randomize 526 people, and we started in December 2021 and we finished in July 2024. So it is important also to notice the inclusion exclusion criteria were slightly different from DISTAL to the ESCAPE MeVO trial. We were mainly focusing on people with a non-dominant or co-dominant M2 segment of the middle cerebral artery, the M3, M4, but also on the A1, A2, A3, or P1, P2, P3 of the posterior and anterior cerebral artery. We were also excluding people who were bedridden or coming from a nursing facility or people who had an in-hospital stroke. At the end, we were able to randomize 553 people. The good news was that no patient was lost to follow-up. Median NIH was 77 years. A little bit more than 1/3 of the people were older than 80. So if we compare that with the Hermes population, these people were older, and time to randomization was roughly 3.8 hours. The rate of intravenous thrombolysis was around 62 to 68% in both treatment arms. And as in the ESCAPE MeVO, at 90 days, there was no difference in outcome in the two groups. So overall modified ranking scale of 0 to 2 was between 55 and 57% in both treatment arms. So a good functional outcome, but no difference in both treatment arms. Similar to the ESCAPE MeVO, there were no major device-related complications. There was a small trend that people with a high NIH at baseline might have a better outcome if they were treated with endovascular therapy, but overall, no clinically significant difference in between the two treatment arms.
Many congratulations, Professor Fischer, Professor Sikogios, and the DISTAL team for this amazing accomplishment. The first question I'd like to open up is, why do you think the results of your trials were neutral? Very astonishingly similar results, similar findings, which really supports the consistency of what we're finding. But what do you think it was? Was it the selection criteria? Was it the devices, the procedure, the endpoints? Where do you start?
First of all, I think we have to notice medium and distal vessel occlusion is not a large vessel occlusion. Good functional outcome in people who do not receive endovascular therapy in a patient with a large vessel occlusion is poor. So modified ranking scale of 0 to 2 is only happening in 27% of people with a large vessel occlusion, whereas it's happening with 57% of people with a medium to distal vessel occlusion. So to improve that destiny of these people is much more challenging. Second, a medium and distal vessel occlusion is not a homogeneous disease. It's quite a heterogeneous disease. We all know that the clinical picture of a patient with a M2 occlusion in the left anterior MCA territory is not the same as with a M2 in the posterior right MCA territory. So there is a huge heterogeneity. And then there are many other reasons. The age was significantly higher in people with medium distal vessel occlusion trials compared to the Hermes collaboration. Treatment was started later in the MeVO-DIVO trials compared to the Hermes collaboration. IVTPA rates were lower. And last but not least, the inclusion and exclusion criteria were much broader in the MDVO trials compared to the large vessel occlusion trials. What is still reassuring is we couldn't observe any major harm.
That's great. Over to you, Professor Goyal.
Well, I could make it very short and just say ditto, but I'll try to add something over because I completely agree with what Urs has said. The other thing that happens in any surgical randomized trial as opposed to a medical randomized trial is the issue of equipoise at the level of the institution, at the level of the collective, versus what you see when you're standing at 10 a.m. in front of a patient and their family. The patients who are most likely to show benefit of endovascular thrombectomy in a trial, by definition, they are the ones that are best for thrombectomy. That's just how it goes. But if you already know or have a feel around who those patients are, then it puts a big dilemma in front of us when we are out in the field, not sitting in an academic enterprise, talking about it in a discussion format. And that is a real struggle that happens in all surgical trials, but more so in our field just because we seem to know based on the last 10 years of cumulative data. We have a gestalt, all of us who when you're down in the trenches, related to who those patients are. And that may be part of the reason why the average age of patients was older. That may be part of the reason where average NIH in both the trials was 7, 8 as opposed to 10, 12. So it's possible that those patients were outside of the trial. But as we move forward, I'm not sure it'll be easily modifiable. It's possible that as a consequence of these trials, there's an increase in equipoise, similar to what we saw in 2013 when the trials, IMS3, etc., finished. And we had a very clear idea about where we are going next. And here it's going to be, in my opinion, multiple small things that will need to happen, as opposed to a few big things. For example, at that time, let's do a CT angiogram, let's move fast, let's get the vessel open. That was a big picture summary in 2013. We were so committed to moving fast that the acronym for ESCAPE included this idea of super fast recanalization and quick workflow. But I'm not sure that is that straightforward right now. Opening MeVos is technically more challenging and more time consuming. And there's also the part about the technical skill. And then once you go into the M3, is it easy or not? And what's the optimal thing? And in our trial, the MeVO picky, which is sort of, we described it in GNIS, it was 75% 2B3. And obviously one would like it to be 95%, but I don't think it's easily achievable. Another thing to keep in mind is that if you look at the history, even the trials that we ran, say ESCAPE versus ESCAPE NA1, there was a substantial jump in 2B3 recanalization that happened across the world. But at the same time, I don't think this is going to be that straightforward. And from 75%, we'll just straight away jump to 90%.
I fully agree that the question of clinical equipoise is most likely one of the major drivers why these trials were neutral. And I would also like to emphasize as a clinician how difficult it is if you do have a patient with an NIH of 11 with a codominant or non-dominant M2 occlusion, and you should sacrifice this patient for a trial when you already know that endovascular therapy can open the vessel, and we know that reperfusion is the most relevant predictor of good functional outcome. So I think that might have hampered the trials quite a lot.
Thank you. These are great insights. And picking up on the issue of dominant versus non-dominant M2, Professor Goyal, this has been a source of a lot of controversy. Many trials did not include the dominant M2 and ESCAPE MeVO did. Could you give us a few insights into to what extent were dominant M2s included in ESCAPE MeVO, and to what extent did that affect the trial results?
Generally speaking, when we spoke to our sites and we were doing the site initiation visit, so-called M1 looking M2, dominant M2, there was no willingness to randomize. So our expectation of having them being part of the trial was exceedingly low, including at our own site. And as you know, we wrote an article from Hermes where we talked about dominant M2s, the M1 looking M2s. So people were using also that article as a way to say that there is lack of equipoise and it's data driven. So essentially, we wanted to keep the inclusion criteria simple: M2, M3, A2, A3, P2, P3. We were expecting that majority of those patients would be MCA patients as opposed to A2, A3 or P2, P3 patients. And that is how it played out in both the trials. But with reference to M2, M3, we really did not have expectation of inclusion of M1 looking M2s.
Urs, any comment?
Same here. So we were fully convinced that if we do have a patient with an M2 occlusion, which is looking like a distal M1, we would not feel that we could randomize such a patient. So that's the reason why we came up with this quite challenging definition. What is non-dominant or co-dominant M2? But basically, it's the same what Mayank said. A dominant M2 was the one just looking like an M1, but just being a little bit more distal. And that was the reason why we did not include these people. It is interesting to see that still in the subgroup analysis of the distal trial, that you see a small trend that the higher the NIH, the more likely it shifts towards benefit of endovascular therapy, highlighting that overall it is possible that there has been cherry picking in the trial and people with the severe handicap have not been randomized.
When we were designing the trial, we looked sort of everywhere in terms of thinking that if the person has an NIH of 5 at presentation, it modified Rankin score the best way to think about it. And then we started looking at it, and we've been working for 2-3 years on this right now. And we created a score which is called Cosmos, Canadian Outcome Score for Minor Stroke. So it's imminently going to get published. We've already got quite a bit of interest in the score, and we've really worked on thinking about how do we evaluate and discriminate patients presenting with relatively low NIH in terms of their outcome measures. And the other thing that we focused in on this idea of what does the patient find important in terms of limitations of their lifestyle and make it more patient-centric. The idea of limitations of modified Rankin score, especially in this population, is something that we really should be thinking about as we go forward. It is unlikely that we will have patients with NIH of 12 getting included in the trial.
I fully agree that the modified Rankin scale is a very crude scale, even for people with large vessel occlusion. I mean, it works, you can show a difference. Nevertheless, with minor and moderate stroke, this is quite challenging. The main problem with all the outcome scores in stroke is that the brain is affected. So if we do have people with aphasia, they often cannot report on patient-reported outcomes. If the right hemisphere is affected, they don't even realize that they're handicapped. The proxies often see the condition much poorer than the patient, him or herself. We do not have a global view on the whole mobility, cognition, patient-centered outcomes yet, and very keen to look at Cosmos.
I'm going to pivot gears a little bit and think about intravenous thrombolysis was highly present in both trials. More than 50% of patients received intravenous thrombolysis. To what extent do you think that affected the neutrality of the trials, and should future trials include patients who receive lytics?
What we found somewhat surprising is that, in fact, the early patients showed some degree of benefit of thrombectomy in ESCAPE MeVO. And that, frankly speaking, to me, when I saw it, came as a little bit of a surprise because it's the early patients who also got thrombolysis, right? So that's one part. The second part was that we had this data set where we did a 4-hour CT angiogram in these patients. And very often we found in the first few hours, actually TPA in those days, now TNK, did not open the vessel. Our thinking at that time was that we should include these patients. At the current moment, based on the data set that we have, it is not that the benefit was less in patients who had intravenous thrombolysis. In fact, if anything, the benefit was more in the earlier patients who had a higher likelihood of having received thrombolysis.
I fully agree what has been said by Mayank. So if we look at the thrombolysis rate, it was 65% in DISTAL and I think 57% in ESCAPE MeVO. But if we go to Hermes, it's 85%. The thrombolysis rates were lower than in the traditional trials, reflecting the fact that we were also including people in a later time window. So eventually, if you want to prove a concept, you should have narrower inclusion-exclusion criteria. However, ESCAPE MeVO and DISTAL trials, they were designed in a period where we said, well, advanced imaging is no longer necessary. Whatever we do with thrombectomy, it has a benefit in the delayed time window, in the very old. And that was also a little bit the reason why these trials had quite liberal inclusion-exclusion criteria compared to the LVO trials. And eventually, having a trial condition where there are no longer low-hanging fruits and liberal inclusion-exclusion criteria is a toxic condition, making you trial neutral. So it would have been much smarter to focus only on M2 segments of the left MCA territory with an NIH of 12 in the first 4.5 hours. However, such a trial is simply not feasible. And therefore, as a trialist, you're always struggling in between feasibility and proving a clinical concept.
Certainly many trade-offs between restriction versus liberalization of trial criteria. I'm going to change gears and think about the devices. So Distal was pretty liberal, let you use whichever device you wanted, and in ESCAPE MeVO, Solitaire stent retriever was the first line. Could either of you comment on the choice of devices and whether that should be changed when you think about the next trial?
Well, there's no straightforward answer to it. I do think If you compare the two trials, there's no substantial differences in the complication rate or in the reperfusion rate or recanalization rate. Overall, big picture, there's always scope for improvement. There is this tendency sometimes to talk about the device in isolation without talking about the operator and the technique, and that's a complex interplay between these variables, not to mention the fact that there's an interplay with the patient anatomy, tortuosity, and the nature of the clot as well. So there are all these factors that have to be considered together. I don't think that's the magic bullet. I don't think that you can say, oh, these trials were negative because it used device XYZ or technique XYZ. If we jumped over to technique ABC, that would be the magic bullet. I think that is unlikely to happen. At the same time, there is always scope for improvement of devices, technique, technology, and training.
I couldn't agree more. Devices can be better. They should be better. They should be more flexible. We should also discuss other approaches in the very distal occlusions, or whether we should exclude them for endovascular therapy. Second, I think also for the interventionalist, opening a large vessel occlusion and the distal vessel occlusion is simply not the same. And I do think that training and experience in more distal located vessels is still lacking, at least in some places. Last but not least, and nobody's talking about that, if we do randomized controlled trials, we only are talking about these first few hours and the first few minutes and the devices, but nobody's going to talk about whether the patient has been admitted to a stroke unit or not, whether the patient had an in-hospital rehabilitation, whether secondary prevention was fine. I mean, you try to approach this difference by randomization, but there's so many other factors which might play a role, where we just don't know whether it was equal in both treatment arms. That we shouldn't forget that if you have a condition where the overall functional outcome is already quite good, and you want to even further improve the outcome of these people, it can be challenging, and such a factor could also then play a role, what is happening after the intervention.
Having done these trials, what are your take-home messages in terms of what should we do with the next MeVO patient that we face? Are there certain subgroups that you say, okay, should not touch with endovascular therapy? Are there patients we should just, yes, go with endovascular therapy, like those dominant M2 occlusions that we spoke about?
A couple of things. One is if the patient has significant deficit and the patient has a more proximal, biggish occlusion and is early onset and the imaging looks reasonable, it is tough to say no to thrombectomy. But also be cognizant of your own skill set. You don't want to produce complications. If the patient's deficit is relatively moderate, be willing to give up sooner. Don't keep trying and end up into like, this is my attempt number 7. I'm very cognizant of that as I say out this summary, I'm actually making it tougher for the next trial. That's a completely separate question that we have to tackle in our entire field. If I'm on call and if I see a 63-year-old with a codominant M2 with an NIH of 11 and the imaging looks reasonable, I will probably go ahead and open the vessel. If I see a 79-year-old with an M3 occlusion with an NIH of 5 who's 5 hours from onset, I probably won't.
Yes, similar here. We need more evidence. And as a clinician scientist, won't stop here. So what we are currently planning is obviously we want to pool the data. We want to see, do we find any subgroups out of these trials where there might be a benefit in order to derive a new hypothesis for future clinical trials. I think that is crucial. We will need more evidence, but it will be challenging, as Mayank has said. Are people willing to randomize a patient 62 with an NIH of 11 codominant M2? It's uncertain whether people are willing that. So in our clinical practice, there hasn't been huge changements. Honestly, we continue treating these people, given the fact that there are a lot of good reasons why the trial was neutral, and we couldn't see any signs of harm. I think we wouldn't do it if we would see any harm. Nevertheless, we need better data for future decision making.
Fantastic. So I'm hearing we need more data. Any insights you can share with us from what you've learned from your respective trials in terms of how you would change your next trial for part 2? Presume that you might plan a part 2 trial.
So one of the things that we need to do as a collective is stop doing 500 patient trials. We need to do 2,000 patient trials. The low-hanging fruit is gone. I've done analysis in terms of NNT, what is acceptable, what is MCID, minimal clinically important difference. So I did this survey. I called 50 people who are well-established stroke neurologists, et cetera, et cetera. And keeping in mind the technical challenge of thrombectomy, the cost associated with this, the infrastructure associated with it, which also plays a role in the MCID. It's different if you're talking aspirin versus thrombectomy. And the general figure, which was amazing across 50 people, was that 5% figure, which means all of us collectively believe that if we are able to demonstrate an absolute benefit of 5%, that's good enough from the perspective of implementation of that procedure, which means we have to design a trial that is capable of detecting the 5% difference. And based on the results of DISTAL and ESCAPE MeVO, and we haven't talked that much about the third trial that was presented that actually showed a little bit of harm, discount trial. I do think one cannot go over optimistic for the next trial in terms of how it's all going to play out. One should aim for detection of a 5% effect size, which will translate to kind of a 2,000 patient trial. And from a practical standpoint, which means it has to be a combined multi-country, multi-center effort across probably Western Europe, North America, Australia, etc. There is this idea that is sometimes promoted that, oh yeah, don't worry about it. We'll do 5 small trials and merge it all together at the end. My personal view is that that is not probably the appropriate thing to do here. We have to set up the trial design so that we are able to demonstrate a 5% benefit. People are putting a lot of hope on this Bayesian analysis, but the reality is the Bayesian analysis, for the most part, is dependent on your posterior probability. And here, if you use distal and escape MeVO as posterior probability, we are back to nil. There is this concept of adaptive trial design, which probably makes sense, but the adaptive trial design may go head to head with equipoise.
Before running into the next trial, we have to clearly look at the data, try to formulate hypotheses, what might be potential cases which might benefit, and for instance, what are the cases who clearly don't benefit from endovascular therapy. If you want to prove a concept, advanced imaging will be key, but we need big data, we need big trials, and this will need a joint effort from many interventionalists.
What Urs mentioned in passing, we have a clear plan, the 3 trials to merge the data together. We are already in advanced stage of working out the details. We should be able to, in a relatively short time frame, be able to put the data of the 3 trials together, or for that matter, any other trial that is imminently coming to a conclusion. I know, Tan, you're involved in Oriental MeVO. We have been in conversations with them as well. As you probably know, discount trial is not, so to speak, completed as of right now. So we are waiting for that to get completed. And that'll allow us probably 13 to 1800 patients in total, which, as Urs mentioned, not only try to answer the question, which is the subgroup that shows benefit, but also answer the question, which is the subgroup that has clearly no benefit, so that we can exclude it the next time around. And I think that second part of what Urs mentioned is actually very, very critical.
Wonderful. Any closing remarks?
As a clinician scientist, after the trial is before the trial. Trials are extremely expensive. They need a lot of effort. You have to plan these things wisely. And I'm looking for the next endeavor.
I like to talk about this term, which you'll soon see in print as well. And we just had an article on this accepted in stroke, which I called WIFU. WIFU stands for WIIFU, what's in it for us. And we have to think about, from a younger people who are our colleagues, who are our junior colleagues, who are probably the boots on the ground, doing the hard work, participating in the trials. Are we able to collectively create enough of a WIFU for them so that they feel more motivated?
Thank you. Thank you both very much indeed. That was an outstanding discussion.